Hi, this is John Malanka with the Sacred Plant. Today we're in Santa Monica, California at Greenbridge Medical with Dr. Allan Frankel. So, always a pleasure.
Great seeing you, John.
Great seeing you
Thanks
as
so
well.
much.
So, we had you in season 1, and back by popular demand, the feedback has been incredible. And so we said, let's continue on with this. And we're going to have some of your patients and their success stories, which we've already included in the docuseries for season 2. So, can you share, why you became a medical professional in medical cannabis? You've been an internal medicine doctor for, I say 34 years?
39 years.
39 years, excuse me. So how did you make that transition from being in internal medicine, MD, now specialized in medical cannabis?
Well, first, I still do internal medicine,
Right.
just with a very heavy bent on cannabis. They're the tools that I'm using.
Yeah.
I grew up in the 50s and 60s, never used cannabis until I was 49. I think a number of people have heard this story, but briefly, I developed a chest and viral infection that went to my heart, became difficult to breathe. I finally went to my doctor, sent me to a cardiologist, and I was in heart failure, very severe heart failure. I was given a dose of diuretics, and they wanted to send me to the ICU. I went home and lost 30 pounds the first night. They gave me 6 months to live without a heart transplant, and I really don't know the reason I chose not to. But that was 19 years ago, so things were quite different. And I'd never used cannabis, but my friends knew that I was miserable, and I was depressed because I was young and unhealthy all of a sudden. And they came over, and I got a bunch of cannabis products and just started using them and enjoying them and just feeling better. But I was also able to walk instead of one stair. I realized I was walking 2 or 3 stairs.
Yeah.
And I developed an interest in learning more about cannabis and started reading and read, tremendous amounts. Things weren't available on the internet back then as they are now, but there were a number of Medline searches and PubMed searches, and there were a lot of studies. And if there were that many studies that were consistent as the way they were with cannabinoids over the last 30 years, that medicine would already be, in use, particularly with the safety profile.
Truly available.
Truly available, legally available, medically available. And at some point might talk about what I think the difference is between medical and recreational. But as I read, I became more and more convinced this was something serious. This was only 3 years after Prop 215 passed, and I'd already written my first few cannabis recommendations, but I wrote them on my regular prescription forms and diagnosis. It was often AIDS back then, and treatment, medical marijuana. And there was a dispensary way back then that was on, I think it was federally owned. I'm not sure who owned that one. But
Here in Southern California?
In Southern California, and these patients would go to that dispensary and get the medicine. And I'd sold my practice because I was dying, and I decided to start medical marijuana, medical cannabis. And for the first few years, I really felt like I didn't know I didn't know anything. So the fact that I felt like I didn't know anything was correct. And I truly feel in the first few years, I learned way more from my patients than they did from me. Then things started changing, but I learned that the patients liked teaching me.
You said you learn from your patients. I learn every day too, but you learn from your patients. It's not a one-size-fits-all medicine. I know I always bring that up in our show. And not all patients can be treated the same. And so I think hearing each and everyone's story and putting that into your expertise and your knowledge and into your practice, I always share that you are one of the top doctors in this industry. From California to Maine, even the patients that we send you from overseas. I think a doctor is needed when recommending medical cannabis. You're not a pot doc. You actually do an intake form with patients. See what kind of medications they're on, see what their health conditions like, and then recommend medical cannabis. So you go over formulations, dosings, the right ratios. So you work with patients. You also mentioned
and new molecules that are becoming
and molecules
available.
now. You also work with patients that unfortunately don't have legal access to this plant, to medical cannabis, and they're forced to become cannabis refugees. And we have a family here today that they're near and dear to both our hearts. And so I can't wait to share that story with our viewers. But, they were forced to move from their state of Georgia out here to California, and they're doing extremely well. I mean, their child hasn't had a seizure in over 3 years.
Yeah, that family has never looked backwards. And this morning, it's okay for me to say now that it's still really touching me.
Yeah.
The family came into my office because they're being filmed today, and the patient, just a young child, was sitting in a chair, saw me, smiled, a couple missing teeth, and just ran over and hugged me. And I was talking to the dad about that I didn't realize that he actually even truly knew who I was, right?
Yeah.
I mean, he only saw me once or twice.
Yeah.
But he definitely associates me with the medicine that he changed to, and his life changed. And I got the biggest hug I think I've ever gotten from a young boy.
Yeah, yeah. And to see how clear-eyed he is, he hasn't had a seizure in over 3 years. He's not wearing a helmet.
Yeah.
We went up to their home the other day and filmed them as a family, and it's a beautiful, blessed, healthy family. So thanks for being part of their journey as well.
Oh, I thank Cannabis for allowing me to do this. I think this is a gift. This was, I just happened to fall into it, and this was not something I would have ever, or anybody that knew me 15, 20 years ago, thought that I'd be doing. But it feels like I'm doing internal medicine, and I just have different tools. That's the only change.
And helping people, and that's what keeps me going, is helping people. I mean, that's why Corinne and I started United Patients Group, to help people, and I'm continuing on in her honor as well to get the word out with reputable information, reputable industry professionals, and helping people. With the laws that just changed here in 2018, January 2018, a lot of people were worried, what's going to happen when the laws change? Is medical going to be pushed out? And I was one of those people. I've seen it. The true medical patient has been pushed out in Colorado, Oregon, Washington, and I was worried about that here in California. A lot of true medical practices, the businesses dropped because they said, people are just saying, I don't need to get a medical recommendation or medical guidance. I'll just go in there and do my own trial and error, and that works for some people, but a lot of people that we work with, it doesn't work. These are true patients that are sick and looking for hope, a second chance. How has it? I know you and I spoke prior to getting on here, but how has the new laws affected your business in a positive or negative way?
Well, in one way, first of all, my business has grown
Gotcha.
since the laws have changed.
Okay.
It has not shrunk. I think but it depends what the patient perceives. If a patient goes into a Walgreens and they might be walking, we see patients all the time walking the aisles, and they're looking for over-the-counter remedies that the pharmacist might be able to guide them with. And I'm sort of comparing the pharmacist now to a bud tender. As long as that's working and they're doing well, why would they need to see a doctor?
Gotcha.
I mean, if the doctor might say, go get a decongestant and you don't need to see me. I think the same thing applies here. I think there's a number of patients, I mean, statistically in the United States, it's under 20% who, and that might grow a little bit, but it's a real minority that use cannabis casually. I think the terms, instead of recreational and medical should be casual and measured. If somebody is smoking a joint, eating a cookie or a brownie, I mean, even though it may have some dosage information on it, you really will never know exactly what you're taking. If you're doing it medically, the doctor, the patient, and the collective all need to know how many milligrams of what cannabinoids and ultimately terpenes the patients are taking. For people who have, which is a very, very small minority, who don't have excessive sensitivity to THC, trying it in a non-dosed way is going to probably work out a good number of the times. And I think people can smoke and have edibles and have medical value. They just don't need a doctor.
So you mentioned a couple things. Well, while we're on molecules, can you explain the difference between the acid form of THCA, CBDA, as well as THC and CBD.
Sure. Um, when you see somebody roll a joint
Yep.
or put some cannabis into a pipe to smoke it, that green stuff is the acid form of the molecule. So assuming for the moment that it's THC,
Yep.
it's actually not THC. Here with THC, it's actually not THC when it's raw.
Yep.
It's THC acid, and it has that extra oxygen, actually a carbon group and an OH group. And when it's heated, that goes off as a CO2, carbon dioxide, and becomes THC. And the same thing happens with the other 115 or so cannabinoids. They all come in nature as the acid form are heated and become the, quote, active form. So up until a few years ago, I remember I was at a conference up in Nova Scotia, and my goal of that conference was to ask Meshulam and a bunch of the other people, very knowledgeable people, so what about THCA? What about these other acid molecules? I maybe asked about 10 or 12 professors, got about 15 to 17 different answers, including that it's not absorbed, including that it doesn't cross the blood-brain barrier. So, but then we started hearing rumors that maybe did have some efficacy. So basically came home from that conference and we made the THCA oil, or I directed the chemist to do it. And we're using it now for lots and lots of illnesses. CBDA, we're having some early luck with myasthenia gravis and some results. CBDA classically is supposed to be very, very effective for nausea. So all the molecules are there for a reason. They've been evolving for a very, very long time.
So educate me here, because I always thought the THCA portion of the cannabis plant was taking it raw, not dried yet.
Well, there's two ways that you can take, at least two ways that you can take THCA. One is just taking
The plants.
raw buds, plants, and I tell people not to use a grinder because that'll generate heat and convert it to THC, but to grind it, and especially for the cancer patients, to take a good gram of that every day and put it in some yogurt.
So eat it that way.
Just eat it? Yeah. There are THCA oils available. There are combinations of these. With regard to the cancer patients, and we now know, there are now beginnings of stage 3 trials with glioblastomas in Europe showing that CBD and THC at doses of like 60 milligrams total per day had a substantial prolongation of life. One of the studies in Europe just came out, but I'm not sure if they're going to be entering stage 3 because the results now that have been released are so obvious that CBD and THC are helping these glioblastoma patients live substantially 2 to 3 times as long. So they were using modest doses of, it's like 30 milligrams per day of CBD, 30
So can they break up that 30 milligrams 10, 10, 10?
I think in the study they did it twice a day.
Twice a day. So
and we usually do
15, 15?
Yeah.
A lot of people can't, a lot of patients that you work with and that we've worked with over the years are very sensitive. And so when I talk to a lot of patients, even after they've spoken to you, and they said, he wants me to take 60 milligrams. And my mom, a good friend of mine who you're talking to right now, she can't take 30 milligrams or 60 milligrams in one shot. And I said, well, split it up then, and ask you if that's okay. The other question I had is, we're here in California. Can you explain the difference between a recreational patient and a medical patient in regards to the legalities? Do patients need to, we work with a lot of other doctors that are patients. We work with a lot of teachers, law enforcement that don't want to be in the system. And so they just want to go into a dispensary and obtain their medicine pretty much anonymously. And so what are the pros and cons of being a legal medical patient or just being a recreational over 21 patient here?
I think at the end of the day, it depends upon whether you're comfortable using cannabis on a casual basis or you feel you really need some guidance. If you're somebody who smokes cannabis in the evening like as a replacement for wine, and you've been doing it for 15 years, you've been getting Rex every year, do you need to see a doctor? No. I mean, the old joke is you need a 12-year-old and a match.
What about the patient that is on other medications? And that's why I always recommend getting them, having some medical guidance,
I think the sicker these patients
yeah,
are, the more reasonable it makes to
yeah,
add a cannabis physician
yeah,
to their annual
yeah,
care. But of course, it needs to be a cannabis physician that's going to be adding information
totally,
that the patient perceives as valuable,
yeah,
not just permission. It has to move, for doctors to
yeah,
remain involved, it has to move from physicians giving permission to physicians giving information.
gotcha,
Because permission is no longer necessary. I think information for those who need it
yeah,
should be available, and that's something that's worthwhile seeing a physician
yeah,
for. And I think the biggest problem out there is not the recreational, because people who are using it casually are going to find
yeah,
recreational stores
yeah,
plenty quickly. I mean, it's online.
yeah,
It's more the sick patient who
yeah.
doesn't know that actual dosed medicine that might be appropriate for them is available.
So speaking about dose medicine and this is speaking my language, it's not a one size fits all. Can you talk about it's not a one size fits all and how important doses and formulations are?
Yeah, I mean, I've been doing this 8 years,
Yeah,
and I mean, certainly have a lot of rules that we
yeah,
follow, but I mean, it's incredibly
yeah,
individual, and that's why there's some various companies now that are coming out with um, genetic predictions
yeah,
about what type, not necessarily what strain, but what ratio, what terpenes might be effective. Um, but I'm certainly going to look into it. I mean, that'd
yeah,
be great if we could order for
yeah,
$100 a genetic profile, and
yeah.
that would tell us what
What's
ratios to use, what terpenes
for
to look
you
for. So,
individually?
but we're gonna do a little study and look into that
Good.
because it's interesting.
Yeah, there are a lot of companies popping up now with all these new types of tests, new types of almost guidance. So
I'm fascinated because I've been doing this for a long
yeah,
time, and I'm surprised all the time.
yeah,
I mean, the number of 80 or 90-year-olds that are using, you know, just THC.
yeah,
And I started them on a 20-to-1
yeah.
CBD to THC, and what finally worked was like a 40 milligram per milliliter THC extract. I mean, how could you possibly predict that?
It's funny you say that because we speak at retirement communities on a regular basis, and every time we speak, I'll follow up. How is it? How was it? How was our talk? Sometimes we bring a doctor in that can talk to them about medical cannabis. But there's one patient that she was probably 87 years old, and she was taking probably about 80 milligrams. And I contacted this. I hate to say the word supplier, but where she was getting her medicines from, and I said, "Time out here. What are you giving an 80-year-old?" And it was an edible, is what it was. And I said, "What are you giving an 80-year-old that high of a dose?" And she goes, she just ordered. And I said, "Well, put on your notes that's just too high." So I went back to the family and I apologized and I said, "How is everything?" She goes, "I don't feel a thing."
Dr. Meshulam
Yeah,
recommends, he told me about a party he had
yeah,
at his house when they were in his 30s,
yeah,
when he talks about how delicious these cookies
yeah,
were. I think they became more yummy as the evening went
yeah,
on.
yeah,
But his wife had made these cannabis cookies that were about 5 milligrams, 10 milligrams, and 20 milligrams. So he was doing some of the early
yeah.
clinical studies. And for most of the patients, 5 to 10 milligrams is plenty.
Totally.
And if somebody's totally naive, 5 milligrams is the most I'll give them.
Yeah. So with that, and I think we see eye to eye on that as well, is microdosing. Want to talk about that?
Yeah, it's actually one of my favorite
Okay.
topics because in a way, of course, it makes all the sense in
Yeah.
the world. It's what we've been doing since day one.
Yeah.
But I read somebody writing an article on microdosing a couple months ago that said instead of eating the whole cookie,
Yeah.
microdosing is eating a quarter of the
Yeah.
cookie. And of course, that was pretty silly and made me laugh. But the dosing that people have used with cannabis in recent years has been measured more often in grams than milligrams. And we deal with milligrams.
Milligrams.
So it's not that these people are going to microdosing, they're just adjusting their dosing to something that's rational. And to me, the correct dose,
Yeah.
always in a patient, and whether it's cannabis or allopathic medicines, is the lowest dose that works for that patient, period. So when I talk about microdosing, what if somebody needs a massive dose?
Yeah.
I mean, what if somebody has, let's say you had excruciating pain,
Yeah.
and your options were either staying in narcotics weren't working or weren't an option. Most people would accept being even frankly stoned instead of being in agony.
Yeah.
So, but it's hard often to convince people that it's, I mean, if I had a choice between being in agony being versus stoned, I mean, I don't know why anybody would have a problem with that.
Yeah.
But people have problems with it.
Yeah.
So sometimes you have to go slow. So microdosing, I think, is the minimal dose that works
Yeah.
for a patient. That's all.
So you must see, we get these calls all the time where patients will say, I'm online, I'm seeing, I need to take a gram a day. And I always say, online, it doesn't say if it's for a 6-year-old child that we have out here coming in, or if it's a 300-pound plus linebacker for, the Los Angeles Rams. And so gram dosing, I think that just...
Well, the gram dosing, as I think we all know, started with somebody who had skin cancer.
Yes.
So I don't know how that leap from skin cancer, because, I mean, who cares how much you put on? There's not that much absorbed through the skin.
Yeah.
But we're having, I think the rest of the world is having good results with much, much lower doses. The glioblastoma, astrocytoma study that's now stage 3 and may be discontinued because virtually all the people who are still alive were in the cannabis arm. So,
and that was taken over. That was overseas, right?
That's overseas.
Was that GW Pharmaceuticals?
GW's Pharmaceuticals. So this was whole plant.
Yeah.
And what made me feel really good about it is here's a study with people with glioblastomas, which are nasty, nasty cancers, who were using 30 milligrams of CBD, 30 milligrams of THC, 60 milligrams.
Yeah.
And all that we've really been doing is adding the acid molecules to it. So somehow a number of us came to the same conclusions as GW.
Yeah.
So either we read something years ago when they were just formulating the study and it just stuck, and we said, well, if that's what they're planning, that's what we should do.
Yeah.
And that may have been what happened, because I don't want to say I'm a genius and I just pulled this out of the air. So I think it started with the GW information, which was the only whole plant information available on the planet. And the acid molecules, I think it's very likely that GW, if they were doing another study, would add those now.
Yeah. So what do you recommend to patients that are self-diagnosing themselves, self-medicating, going down to a dispensary, obtaining it either legally or illegally if they're not in a legal state, and going that route? Can you talk about that it's not a one-size-fits-all? Can you share if a patient doesn't go down the medical route, what would you recommend for them?
Well, I don't think every patient needs to go down the medical route. I mean, if, let's say, you had some back pain and maybe some sleep issues, that it could easily go either way. It could be more who you are. A lot of patients, I think, will go into the recreational store, and maybe some of them are a little more, they've actually read something.
Advanced.
A little more advanced. They might start, maybe they've watched The Sacred Plant a couple times.
Which we have a lot of people. Actually, on the way here, I spoke with a nurse who was in Pennsylvania, and she said, I watched all 7 episodes, not once, but twice, and I took all my notes. And
I had a patient exactly the same.
Yeah. And so you brought up a good point here. Walk me through, but a brand new patient coming into Greenbridge Medical and meeting with you would go through, and the follow-up afterwards. And you can share that.
Well, we really don't give. We used to give patients forms to fill out. But I think most patients. I mean, I don't know about you, but I think most patients, when they fill out forms and somehow it goes in the chart, they think nobody's ever going to see that again. So since I have terrible writing, and as you can see in our office, we have no paper charts. Everything is done electronically. So by the time we see the patient, we like to have their medical records before, because I can't review 30 pages of records when the patient's there, or whether it's a phone or Zoom video. But I review their records, and I ask them to tell me the story about what happened. For example, let's say it's a patient with cervical spine disease or lumbar spine disease, and they have sciatica. How did it start? What makes it better? What makes it worse? what their expectations are,
Yeah.
what their hopes are. And that's a critical question to always ask a patient. What are your expectations? And generally, I mean, they're what you think, but often they're not. I had a patient recently who came in with a cane and he was limping and he had back pain. And I said, "You're here for your pain?" He said, "No, I'm here, I have some anxiety." And he said, "No, my pain's okay." You know, it's like you can't make any assumptions.
Yeah.
You have to ask the people.
Yeah.
And then you need to explain to them what this is about, what their options are, give them 2 or 3 options on how to start. I'll ask them how afraid they are or how anticipatory they are about the cannabis experience. If they're a pain patient, they're going to most likely, except if they're very old.
Yeah.
Some of these plus 90 people have amazing pain reduction just with a 20-to-1 CBD.
Yeah.
But most of us, if it's a bad back or sciatica, we need some THC. And now we're finding THCV, THC Varin, which is new, like CBD was new 8 years ago, is a big deal.
Yeah.
And we're running out. Fortunately, one of the growers actually found some seeds that he ordered. So it's going to THCV, tetrahydrocannabivarin, is going to be a very big deal. I mean, for people, there's like 5 to 7 million people in the country with neuropathy just to their feet.
Yeah.
We've had 40 patients who've tried it on their feet. We have 38 of them are now pain-free.
So you're saying try it on their feet. It's a topical?
Well, it's actually not a topical. It's a transdermal.
Okay.
There's a special secret ingredient in it that allows it to actually set up home underneath the skin.
Okay.
So they can wash it afterwards. And I'm hoping we can get the dosing right and blood levels right so we can also use that for some of the children with autism and seizures.
Yeah. So back to the patients that are coming in here for a consultation. You meet with them for an hour, maybe longer. You are recommending cannabis and the different formulations for them. But what I like about your practice is, and because a lot of doctors, a lot of patients we work with, they call us and say, "What do I do now? The doctor just said, call me in a year if you want to renew."
Important information comes after the visit.
Yes, you have a patient portal, and I know a lot of patients that we send to you will call me up and say, "This has been great because, one, I'm sleeping too much, or my mother is not eating, or her anxiety has risen," and the patient's portal that has access to you is a great little stepping stone for them that they're able to say, "Oh, hold on, let's redial this formulation for you."
But it's not primarily actually meant as customer service, even though it is.
Yeah.
It's the only way that I know to learn.
Yeah.
I mean, when I'm stuck, who do I call?
Yeah. But it's caring and hope, and a lot of patients come to us and you just wanting a second chance, and for hope. You give them hope, and I always share with patients, this isn't the golden ticket or the golden flower, and a lot of patients that we see, and I'm certain you as well, this is either their first stop or their last stop, and with medical cannabis, and
More often, last stop.
yeah.
And hope. I just read a book by Dr. Jerry Groupman, who I actually trained with a million years, and he's written several books, and this was on hope.
Yeah.
And somebody gave it to me because we had a discussion about hope.
Yeah.
And that you can tell a patient, just take their hand and say,
Yeah.
"I really think you're going to do great."
Yeah.
That's it. I mean, are you exaggerating?
Yeah.
Are you lying? You're not lying. You're just saying, "I think you're really going to do well. I'm really optimistic."
Yeah.
And they'll actually say, "Thank you. I really needed that."
Yeah.
That's how desperate patients are for hope.
Yeah.
So the question becomes, why are doctors hope robbers?
Boy, oh boy.
And doctors are hope robbers, and I think I figured out the reason why. It's so much easier to say, nice working with you. You probably got another week or so we're going to cancel
you had a good life.
we're going to cancel the appointment for next week, and we'll fill it up with somebody else. I've heard stuff close to that. I've heard you have 2.5 weeks to live. 2.5 weeks to live. I mean, that particular patient, because 2.5 weeks is pretty remarkable.
We had that with Corinne's dad. He's still alive.
We don't know. I always take those patients and I slowly turn them around and say, I don't see any expiration tags.
Yeah. Yeah.
Yeah, we don't know. And hope, I mean, hope, by the way, is probably largely managed like the placebo effect. I mean, we tend to downplay the placebo effect and say, oh, it's a placebo, that means the patient's not in pain. I mean, that is criminal. It's very, very unethical to do. And you can actually get in trouble for saying that now. But hope gives people everything. You don't have to be sick to need hope. We need hope all the time. I hope that I make it home today. I hope my kid wins the game. I hope this, I hope that. And you're going to win the game. I mean, what do you say? Nah, it's really, they lost the last 2 games, man. He's probably going to go home crying. You're going to have a miserable weekend. I mean, when I went to Israel to visit Meshulam, several of my good friends, these people I think like me, they said, don't get blown up, don't get shot. I think, okay, what do I do?
I hope I make it.
I hope I make it. And then somebody said, Allan, have a great trip, and I want to look forward to seeing you when I come home. I said, thank you. So hope, we tend to dole out hope in small amounts here, and I don't get it. I mean, you can't be effusive so that it comes off insincere. But people are so desperate, it's better to be effusive and insincere and give hope than say, now you've got 2.5 weeks.
The conference I will be doing in a few weeks here, that you and I will be going down to in Florida, the first time Corinne and I attended about 7 years ago, we were part of a panel. Actually, we weren't the panel, we were in the panel discussion. And a question from the audience is, what do you do when you work with cancer patients? And these are all international oncologists. And I couldn't believe, the first one says, I always ask, what's their, how's their morale? What's their home life like? What is their will to live? And then he said, then we ask what their spirituality is like. He says, a lot of times we say a prayer with them. And then we go into treating. And Corinne and I looked at each other and said,
wow.
That's beautiful.
That's beautiful. I am amazed that a system that was found in 1984, all right, that's 30-something years ago, is still not being taught in more than, I think, maybe one medical school. The endocannabinoid system's a huge system in our bodies. Like we talk about our nervous system, our vascular system, big pulmonary system, big systems. This is just as big. I mean, every neurotransmitter that crosses every nerve circuit anywhere in our body is monitored by our internal CBD and internal THC. These are anandamide and 2-AG molecules. And when you have monitoring of transmissions, you have normalizing. And the endocannabinoid system and the phytocannabinoids that are in the plants are a matter of they're modulating medications, or it's modulating nutrition. I mean, I personally believe that this is all, at the end of the day, like everything else, just good nutrition. The plant's a vegetable, so from vegetables you get nutrition, and humans have just put too much THC into it and made it a little bit more uncomfortable for people. And I think the ultimate cannabis medicine would be if you could go back in history, which is possible, to figure out what molecules were most likely in the average plant 100, 1,000 years ago, and THC was at 1.5%, CBD was at 1.5%, probably there's a little THCV, little teeny CBDV, those, and recreate that plant in a bottle.
That'd be nice.
That's one of my goals of life.
Okay. Well, you still have many more years on this earth.
I hope.
Terpenes. You want to touch up on terpenes?
Oh boy, it's the biggest. I mean, terpenes and minor cannabinoids and flavonoids and plant waxes and plant lipids and all these other categories of medicines are all going to be very, very important for us to better understand. The problem is we don't have a way of monitoring them well enough. Pretty much every extraction gets rid of most of the terpenes, and that's why we're going more to gentler presses rather than CO2. But you always are losing terpenes. When you decarboxylate a medicine, the issue is losing terpenes. But we're constantly making efforts to have terpene preservation using combinations of cold traps and different ways during the decarb.
And I don't mean to interrupt you. You want to talk about decarboxylation?
Sure. Well, decarboxylation is changing the THCA,
Yeah.
heating it, and ending up with THC,
THC.
or the same with any of the other cannabinoids.
Yeah.
And decarboxylation is something that we thought was always necessary to get any value from the medication because you wanted to get that stony effect.
Yeah.
And that carboxyl group that comes off with heating protects us from getting stoned. THCA with the carboxyl group doesn't have any. It has tremendous nutritional, anti-cancer, and neuroprotective. I think it's going to be the mitochondrial cannabinoid. That's
So, every year there's another discovery, and what's beneficial. Can smoking, ingesting THC, or ingesting cannabis, or vaporizing cannabis, or dabbing, which a lot of people are doing now, can that fight off disease?
Well, sure. I'm not a dabbing fan.
Yeah.
And particularly not a dabbing fan. It's not because I've never done it, and I haven't done it for years though, because we're seeing more and more of this cannabis emesis syndrome.
Yep.
There was one of my own.
And will you share with our listeners about cannabis emesis?
There's a syndrome that we don't know yet whether, I think it's becoming more common because of dabbing. But generally it's not always, but generally young males that are doing a lot of dabbing get to a point where unless they're ingesting large milligrams, they're vomiting. And the only thing they can get relief from is hot water.
Oh.
The first cannabis emesis patient I saw in my bathtub. I was having a little get together with a bunch of cannabis people, and one of the guys there that particularly did a lot of dabbing said, "Can I use your restroom?" And I thought, okay. And I didn't pay attention that an hour later he was still in there, and I just walked in to use the restroom, and there's this guy in my bathtub, and I ended up talking to him, doing a consult there because he was so sick and he was vomiting in my bathtub. And that's when I looked it up, and that was the first cases were being. But these people are sick, and they either need to just stop using THC, or some of them will get better if they can just moderate their THC dosage. Adding CBD helps most of them, and a lot of them have to quit for a while. And there's just a level
and clean the
and let the receptors recover. But I don't recommend dabbing any longer. I mean, it scares me. What if it's possible? I mean, we like to think this is a pretty safe medication, and I think it is, but if over years you're putting hundreds of milligrams of THC past your receptors, I just don't think that's a natural thing to do.
So a patient, who lives in a legal state, they'll have access to a dispensary or another legal supplier. What are the top cannabinoids they should be aware of and look out for?
Well, I would say that the top 4 for today, one of them is just becoming available, but it's worth talking about for a moment because it's going to be such a big deal. I mean, if you knew back in 2007 that in 2 months CBD was going to be available at all these stores, and you were on a show like this, you'd mention it. So that's the one exception. Not quite available. So CBD, let's start with that. That's the molecule right behind my head. The single biggest thing to be aware of with CBD is where that CBD came from. Is this cannabis-based CBD or is this hemp-based CBD? Now, there are arguments by the people, of course, who make hemp CBD that it is equivalent. It's not. I mean, certainly every experience I've had, every test that's been done with the entourage effect in Israel, and also the quality of the products are just completely uncontrolled. And what happened is in China and Eastern Europe, they've been growing hemp for the purposes that hemp really should be grown for fiber and paper and everything else. But there is small amounts of CBD in it, but the hemp has been sucking up heavy metals from the ground. Nobody intended for people then to start squeezing out tiny bits of CBD using gigantic CO2 extractors and then ship it by the crateful all over the world. And it's not that it doesn't have CBD, and the molecule is the same in the hemp plant and the cannabis plant, but the hemp plant is missing the entourage effect, the hundreds of other molecules. And most of the, not most, but maybe half of the patients I see have gone, and because you can get hemp CBD anywhere, to go into a store and try it, and they usually get a headache and nothing much happens, and that's when I see them. And I see probably a third of my patients after they've already had a recommendation trying to figure this stuff out. So people going in, the first thing they need to try do is, of course, if they're sick patients, I recommend they speak to a physician. But if they're more casual and they're just looking for some help with a little sleep here or a little pain here, I would generally recommend that they start more with the CBD because you're not going to have any problems with it. So CBD.
And when you say problems,
psychoactivity.
Psychoactivity.
You'll have calming and focus, but you're not going to have any stoniness from it.
But a lot of patients hear that. They say, I can take as much as I want. I have anxiety, I can take as much as I want. Have you seen too much CBD inducing anxiety?
That's a good question.
Because we get a lot of patients that will say, hey, I took all this CBD.
You know what might be happening?
Huh.
This was a rumor that turns out to be true. We actually do, it's not so much that it happens in the stomach, which was the big deal about all your CBD is converted to THC, but some of CBD that we ingest as it goes into our bloodstream is converted to THC. And some people convert more than others. And how to figure that out as a doctor, we need a lab, in case any really wealthy people are listening or like to donate, we need a lab, not to test the cannabis. We have lots of labs like that. We need labs to test our plasma levels. That's something we critically need access to. But CBD is, as a tincture, as a spray, 1 or 2 sprays, if you have some general anxiety, even if you have some pain, it's something worth trying. And I would start with 3 to 5 milligrams under your tongue and spread it around your mouth, and don't eat or drink for 15 minutes. That's a really safe way to start. And even though it's just CBD and with very little THC in it, the first time you do it with somebody there, and do it at home. If you're somebody that maybe has a little more pain and the CBD with a 20-to-1 ratio isn't working well enough, try go up to a 2-to-1 or 4-to-1 with more CBD than just with a little bit of THC into it.
So 4 parts CBD, 1 part THC.
Exactly.
A lot of people think CBD is the medical
and THC is the recreational.
or the bad. And I don't want people to be afraid of THC. Some THC is needed. Entourage effects is a proof right there. But can you share that some THC is needed?
Well, for sure, some THC and all the rest of the molecules are needed. And that's why I think the medicine of the future is going to have very small amounts. I mean, we are thinking of making seizure medicines that have 3 or 4 different in smaller doses. Why not use CBD with a little bit of THC, with THC-A and THCV, and ultimately CBDV? I mean, those are going to be the seizure medicines of the future. They're going to be these complex cocktails, and perhaps the total milligrams per milliliter will be the same, but it's just going to be like it was hundreds and thousands of years ago, with small amounts of each one. There'll be no side effects, I would imagine, and definitely be something we'll be trying in the next year or so.
For cancer patients, like Corinne's dad, he was 4 parts THC, 1 part CBD. How important are formulations and ratios with different diseases?
Well, trying to combine both these questions into one. THC, I mean, adding THC is going to help more with pain. It's also going to definitely be more effective for cancer. I mean, from my reading, I think, and certainly with this clinical trial that's just been released, it was 1-to-1. So we're doing 1-to-1-to-1-to-1, and we'll be, I'm sure, adding, once they're available, THCV and CBDV, because they have substantial anti-tumor effects. And why not stay to 100, 150 milligrams, but divide it between all the molecules that have anti-cancer effects? I mean, why should some have it and some don't? So we've talked about CBD, the psychoactivity of THC, substantial anti-cancer benefit. Overall, I mean, it depends who you talk to, but there's large groups around the world that believe, and I do, a one-to-one is the best for most, solid malignancies. Then THCA.
Yeah.
THCA is, as those tinctures appear more commonly for nausea when THC doesn't work, or you're very afraid of psychoactivity. THCA is definitely worth trying for that. And for patients with Parkinson's or dystonia or cerebral palsy who have a lot of spasticity, all of these molecules can help. But I would stick more with like CBD and THCA. And one that you're not going to be able to find today, but you will find in the months to come, is THCV, V as in Varin or Victor.
Varin,
yes. And it's basically the THC molecule with the last two bumps cut off. That's the only difference. The first time I tried it, it was the first time I ever had pure euphoria. It wasn't stony. It was a spray that had like 1 or 2 milligrams in it with 1 milligram of THC, and you just felt happy. Great for neuropathic pain, and THCV are going to be a gigantic deal next year. Huge. I mean, for the people with neuropathy of their foot, if you can figure out how to get that THCV through their skin, it works unbelievably well. I mean, 2 patients I had in the same day, it was an amazing day, they came in wheelchairs because they had the burning pain, but they had no feeling also, because it hurts the nerve on a couple ends of the nerve. And they took the cream, and they actually are still walking. They never used a wheelchair again.
What do you say to patients who are watching us who don't have legal access? They live in an illegal state. They're looking for hope, one last hope. They're looking for, hope. I mean, we were very fortunate. We live in California. We live in California, and the end result is my father-in-law is still alive. Cannabis was not our lifestyle. We weren't looking at it as the medical benefits. We were looking at it for appetite stimulation, which it did. And the Cracker Jack prize is that it also killed his cancer cells. So we happened to we were very fortunate. We lived in a zip code in a state that allowed legal access. So we work with so many families that don't have that access. And a lot of them are told sorry. A lot of them are have to move and become a cannabis refugee, move from their families, their jobs, their neighborhoods, their doctors, to come out here and start a life again, just for hope that it can help with themselves or their children. So what do you say about the laws that, like you said, that not really protect the laws against for medical professionals in recommending medical cannabis? But what about laws for patients?
Well, I think we both agree they're ridiculous. And we always tell patients when they are scheduling the appointment that they're in a state that doesn't allow it, so there's going to be some challenges. But we're Americans. We're going to push. And where there's a will, there's a way. And if you have a child that's suffering, let me tell you other things people have done. And I'll tell them that they sometimes will come out. It used to be easier when California made it, but people can use leases. Recreational is available now. It's available in a lot of other states. We have a lot of patients just get CBD, THC, and THC as shatter in Colorado, and then tell them how to mix it up and then make it into dosed capsules. So that's probably the most common thing we do. And now it's, in like New Jersey and New York, how they figured this out is, they must have been the dumbest people ever. New Jersey is all bud. New York is all oil. Now, they don't make very much THC
Yeah.
THCA oil in most places because it's a bit of a challenge. Although in California, it's certainly becoming more
Yeah.
common. So often the THCA will just tell people to take a half a gram of
Yeah.
raw bud,
Yeah.
crush it, and
Go that way. It's funny you say that because we just returned from Maryland, and we talked to people out there in dispensaries, and we asked about THCA. They knew nothing about it yet, but now they do. So hopefully that will be available to patients in legal states, both recreational and medical. So Alan, so I know you see a lot of patients, and we refer a lot of patients to you as well. Fibromyalgia is one, myasthenia gravis, which I think you're the only doctor that I know who has really, I'll say, perfected formulations for that patient group. Seizure disorders, which we have a patient in here today with DEW syndrome, which is a rare type of seizure disorder, and then but cancer and anxiety, sleep issues, autism. I know I've sent a couple friends in where their children have autism, and they're finding a lot of success. My aunt was in here with COPD, and you helped her. So today we have a few patients coming in. One is fibromyalgia, and one is myasthenia gravis. Can you talk about those two type of conditions?
fibromyalgia is very, very common, not as
Yeah.
exciting as somebody from with myasthenia gravis. But fibromyalgia, I've always felt, is a disease of disordered sleep.
Yeah. Yes.
If you look back and talk to them about what was going wrong first, it was some sleep disorder.
Yeah.
So I usually treat them with CBD during the day and add a little THC at night. Just get them to sleep better.
Yeah.
And with sleep disorders, I break them down into two types, just very briefly. The people who have troubles falling asleep and the people who have trouble staying asleep. The people who have trouble staying asleep have elevated cortisol levels during the day and the night, almost always from anxiety.
Yeah.
And then their cortisol levels that are the early morning elevations of cortisol wake them up.
Yeah.
So instead of waking up at 6 or 7, they wake up at 1, 3, 4 in the morning, very agitated, difficult to go back to sleep.
Yeah.
If you give them let's say a sleeping concoction of cannabis, sleeping pills, don't work. They still wake up at in the early morning,
Yeah.
and then they're groggy. If you give them CBD during the day, you treat their anxiety, and you can pretty much then not give them very much at nighttime. Just deal with it during the day. Myasthenia gravis is a complex neurological disorder. It also falls into the mito diseases, the mitochondrial diseases. And these are patients that can present, usually young adults to older, it usually starts with double vision. They have weakness of number of eye muscle groups.
Okay.
It's a disease related to the energy production of muscles by the mitochondria. And we think that's why THCA helps.
Yeah.
And the first patient that came in was 3.5 years ago. And I've seen a lot of MG patients in my life because I was UCLA trained. We see rare stuff, not so much the common stuff sometimes. And she had just been out of the hospital, was on a ventilator. Her chest muscles were so weak. She was on 60 or 80 milligrams of prednisone, 3 or 4 other drugs, intravenous immunoglobulin given to her, and she got off of everything. And since then, we were treating her with CBD and THCA, and now we're using CBD, much more THC and THCA, and I think it's going to end up being the same protocol, that these 4 or ultimately these 6. I mean, I can't wait to try it on with THCV and CBDV.
I thank you, and we'll bring some of your patients in and share
Put me to work, huh?
their success stories. So, anyway, I thank you, and we will keep going.